So I welcome you all for the joint webinar between Asian Association of Transfusion Medicine and NRL Australia. Before we begin, I invite Dr. Wayne Dymack to say a few words and introduce the webinar, the concept, and share a few words with us.
Thank you very much. It's a very big pleasure for NRL to be collaborating with AATM on this presentation. We have a mutual focus on improving the safety of blood screening across the Asian region, and we're really pleased to be able to participate in this session, and we expect to have another session later in the year. I'd like to introduce my colleague, Vee Armstrong. Vee is a senior scientist at the NRL Scientific and Consulting and Training team. She has 32 years of working with the Australian Lifeblood Blood Transfusion Service in Australia as the National Quality and Regulatory Affairs Manager. She also has spent 5 years providing capacity building to the Indonesian Red Cross, and also has been contracted to APEC to provide GMP training and assessment to Vietnam and other areas. She's co-chaired the WHO Working Group on the development of guidance documents to centralize blood services, and is currently supporting capacity building with NRL training team across diagnostic and blood screening laboratories in the Asia Pacific area. Vee is going to be presenting on GMP practices, and I'll hand it over to Vee. Thank you very much.
Thank you very much, Wayne, and I'll go back to my slides now, and hopefully we can see everything. Now,
Ms. Vee, we can see the presenter view. You need to change the view for us.
Okay, let me go back. Okay, let me just come out. My apologies for this. Just looking at how to get back here. I'll lose all my screen here, so I'm not quite sure where to go. So let me minimize that one. Okay, can you see anything better now? Okay, I'm ending the show now, and I will just start again.
Ms. Vee, before we start, I have to take it's my pleasure to introduce our chairperson for the session, Dr. Nidhi Bhatnagar. She is the current chair of Quality and Accreditation Working Group of Asian Association Transfusion Medicine. I would request Dr. Nidhi Bhatnagar to please introduce Ms. Vee formally. And may I request Ms. Vee to please stop sharing. I'll share your CV here.
Right.
So first of all, welcome everybody to this joint webinar of NRL and AATM Working Group Quality. And I'm so thankful to Vee for agreeing to take up this so important topic today with us. And just to introduce Vee, she has a 32 years experience with Australian Lifeblood, 20 as National Quality and Regulatory Affairs Manager. And we've had earlier some interactions with Vee, and yes, I mean, it was a wonderful interaction. And she's also had 5 years providing capacity building and training in GMP for Indonesian Red Cross blood establishments. So today also her topic is GMP in the blood transfusion. So I think we are all going to be very much benefited by by her talk. She is contracted by APEC to provide GMP assessment and training to 5 blood services in Vietnam and to develop white paper on establishment of centers of excellence. She has co-chaired WHO working group to develop guidance document for centralization of blood services, and currently she's supporting capacity building of diagnostic testing labs through virtual and in-country training in the Asia Pacific region. So again, a warm welcome to everybody, and especially Vee, and I hope everybody enjoys this webinar. Over to you.
Thank you, Dr. Nidhi. I have this pleasure of introducing our next chairperson, Dr. Gajendra Gupta. Sir is the chairperson, AATM India chapter, and is the pillar behind the functioning of Asian Association of Transfusion Medicine. I request you to say a few words, sir.
Yeah. Good morning, everyone, and I'm so delighted. This is my second chance I'll be hearing to Vee, and I assure you, she's a very dynamic speaker and a trainer. I think that's what we require as of right now, and I think the participant will be highly benefited. I'll not take much of the time. Vee, please start your presentation. We want to hear from you.
Thank you very much, Dr. Gajendra. I will try my best to get the sharing right now. So let's start again. Come on. My apologies, my screen's a little bit slow at the moment. Right, can you actually see the full screen now?
No, we are still looking at your presenter view.
Oh. Okay, my apologies for that. I'm not quite sure. Let me come back out and see. Go on here. Okay. Still presenter view?
Yes, Miss V, still presenter view.
Okay, my apologies. I did test it earlier and it was working fine. So let me just go back and see if I can change my, I don't know. I've got a computer.
May I request you to do a small change? Please
Yes.
go to the option of slideshow. On the top of it, where you're in the menu bar that says File, Home, Insert, there's an option called Slideshow.
Yeah, it's just that I've got animation in mine and I'm not sure how that will go with that.
But it is visible if it can be done on the full screen. It's not the...
Yeah. If you can do it like this, it's visible. Yeah, that's good.
That's okay?
That's okay.
All right, well, let's go ahead with this and see. My apologies for this. As I said, I've actually got a slightly different computer that is not behaving itself terribly well. Okay, so, and can you actually see my arrow as a pointer?
Yes, we can.
Yes,
Oh,
we can.
sorry. My apologies. I have a dog who barks and I can't shut her up. She's very noisy. Right. Okay. So thank you for Hazel, come on, stop it. Thank you very much for inviting me to speak, and particularly on a subject that I'm very, very passionate about. I'm extremely passionate about quality and all things quality, but in particular, I'm really passionate about good manufacturing practice. And I'm really sort of pleased to have been asked to come and address you. So what I'm going to do on this presentation, I'm going to provide just a reminder of a blood services obligations to its customers. I'm going to provide an overview of GMP, what it is, why it is so important in the manufacture of blood and blood components, where to find its requirements and what those requirements are, and why it also needs to be linked to a separate document, in other words, a blood standard. Just before we go on, in terms of terminology, I'm afraid that sometimes I use different terms through the whole presentation, but blood donor centre, blood establishment, blood service, I sometimes use them interchangeably, but I all mean the same thing, a place where you collect and process blood. Quality system and quality management system both have the same meaning, so no matter what I've put in the presentation or what I say, I'm meaning the same thing. When I talk about the manufacturing process or the manufacturing chain, I'm talking about the whole process from the time the donor walks in and registered till the time the donation or the components actually get sent out of the door to your end user, to your hospitals. And I'll use the term processing, which is particularly the separation of donation into components. So those, just to clarify that those are the terms that I will be using. Now, I know that this is a little bit old school, but quality is all about providing good service and good product. So we need to think about our obligations to our customers before we start even going down the pathway of talking about good manufacturing practice. Who are our customers? Well, most people will say they're our patients, our clinicians, our hospitals and funding bodies, our donors, and our obligation is to meet the needs of those customers. But what are their needs? So if we look first at patients as being our biggest group that we think about, what they want from us are blood components that are available when they need them, components that are safe, in other words, free from transfusion-transmitted infections or TTIs, and free from contamination. They also want blood components to be of good quality and in particular to be efficacious. It's no good for us to provide a bag that's chock-a-block full of platelets to a patient needing platelets if those platelets have been stored badly and have lost their function. So it's really important that what we provide is not just good quality, but actually still works. Our clinicians and hospitals always want an uninterrupted supply of efficacious components. The challenge is that they usually want as many as they need, as often as requested, and all delivered in good condition. Now, the first 2 points here are always a struggle for blood services to meet. Sometimes supply just cannot meet demand. But we try, and we try our hardest to deliver. When we look at blood donors, we're very keen, or they are what they want when they come in, they want a safe environment in which to donate. They don't want their own health to be affected through the actual act of donation, which is why we need to do a health screen on them. They don't want to be harmed during the donation process. So it should be very quick, should not infect the donor at the venipuncture site, and should be relatively pain-free. And of course, they want to be assured that their confidential personal information is well protected. Now, when they donate, they're giving blood, and they want us to handle that blood safely, because they're giving it to us altruistically to provide to our patients. So they want it handled safely, they want it protected from contamination, and they want the way we handle and protect it to maintain the integrity of that donation. The other thing is they also want to be appreciated, and this is sometimes forgotten. GMP doesn't actually cover appreciation for blood donors, but as a service provider, we need to make certain that when blood donors come in, they have a good experience. Because if they don't, if they're not made to feel welcomed and looked after, and you know we don't show our gratitude, then they won't come back again. So they want to be appreciated. We need to provide them with that level of appreciation. Now, what I've added at the bottom here are our staff, because even though our staff are not really truly our customers, they are an extremely important part of the way we work. And they have a right to expect to be able to be working in a safe environment where there are good infection control policies, they're given PPEs to wear, and they are trained effectively. They want to be able to work in safe workflows, and the processes and equipment should be safe for them to use as well. So GMP does look after that aspect. And if you look at the two things that I've got in the box here, the donation and the safe environment, these together also support good quality, safe, efficacious component production. So how do we fulfill that obligation? Well, obviously by ensuring that we can provide blood and blood components that are safe, high quality and efficacious, available when required, and sufficient in the numbers that are required. Now, the only problem is that things unfortunately can go wrong in our centres, because when we collect and manufacture blood components, we have equipment and materials, in other words, reagents, etc., blood packs, that are being used in processes by people working in facilities. So we've got 5 different areas here, or 5 different factors, and problems and failures and errors can occur anywhere along that chain. And the chance of these problems and failures that can occur, we obviously call risks. And if they occur, these can affect quality and safety. Now, just looking at the risk, a risk is a possibility or something, a potential for things to go wrong or fail. And an example I've given here is of samples being mixed up. If you have 2 donors and one nurse is collecting from both donors, and they happen to be a left arm, right arm, so the nurse is between the 2 beds and collecting there from both sides, if the work is not controlled, it's possible that the labels for one donor can be put on the samples and for the other donor. Now, if the samples are mixed up, then obviously that risk affects our products. So it has an impact on the quality of our products. So it means that one of our donors now has an incorrect TTI result, possibly. I'm talking worst case scenario here. Those impacts in turn can then cause harm to our customers, in that these are the consequences. So in fact, what would then happen is we would have some positive TTI results. We would go and collect the donation, which now is the wrong donation because the mix-up, it doesn't match the samples. We'd throw that out, and the donation that actually was truly positive goes out the door and infects the patient. So this is an extreme risk, but it can happen. I have known samples to be mixed up, but thankfully I have not known incorrect TTI results. What I have known is incorrect ABO groups. And thankfully, because hospitals tend to check the blood groups on our blood donations, it was detected. So, you know, this can happen. This would be a worst case scenario. And as a blood service, we need to control or manage those risks. And the best way of controlling or managing those risks is to implement good manufacturing practice, or GMP. So if we now look more closely at GMP, a brief history to set the scene. And it's really interesting, and it's quite relevant to understand the history. Way back in 1937, and oh my goodness, that's almost 100 years ago, a number of people in America and other countries were poisoned by new cough medicines that had come onto the market, and these contained sulfanilamide. And so that sulfanilamide caused poisoning of those people. So within 12 months, the USA had introduced regulatory control of pharmaceuticals to try to control the sorts of ingredients that went into medicines. All went well until the 1950s, where particularly in Europe, the thalidomide tragedy occurred, and the whole subject of control of pharmaceuticals and controlling the manufacture came up again. And finally, in 1962, the phrase good manufacturing practice was first used. A few years later, in 1969, WHO developed the first GMP guideline for pharmaceuticals. Then, of course, it took another number of years until 1980s and 1990s, where we started having the unfortunate situation where a lot of our fractionated plasma products were becoming contaminated by HIV. Because we weren't screening donors, HIV was new, people didn't know a lot about it, and the fractionation processes weren't rigorous enough to heat inactivate the HIV. So in 1990s, and in Australia this occurred in 1992, regulation of blood and blood components and codes of GMP for blood were introduced in a number of countries. And as I said, Australia was introduced it in 1992. So it's interesting to see that it came originally from medicines, and finally blood was recognized as a type of medicine. So what is GMP? It's a set of principles and procedures that, when followed, helps to ensure that therapeutic goods, and I will come back to this word later, are of high quality. And a basic principle of GMP is that you cannot test quality into a batch of product. So no matter what testing you do, it's either going to be a pass or a fail. You cannot build quality in unless you do it through the whole manufacturing process, and you're doing it at every stage. So all your processes are built around quality performance. This definition came from our TGA, which is our regulatory body here in Australia. Now, GMP principles ensure the quality and safety of therapeutic goods by basically preventing or reducing the following risks from occurring. And GMP is based all around risk management. It's the best risk management strategy that a blood service can put into place. So it really focuses on trying to reduce errors, failures of processes, materials, and equipment, unsuitability of buildings, premises, and facilities, inadequate or lack of traceability, uncontrolled changes, and contamination and cross-contamination. So just coming back to this word, what do we mean by therapeutic goods? Now, it's actually important to understand this, because therapeutic goods are health-related products that are for use in humans. For example, preventing, diagnosing, curing, or alleviating diseases, etc. And the examples are basically fall into two categories: medicinals, like drugs and medicines, or biologicals, such as blood components, human tissues, cellular therapies. Now, therapeutic goods also include items that are used as an ingredient or a component in the manufacture of therapeutic goods. In other words, our blood components are not the only therapeutic goods we work with. Our blood collection packs, the anticoagulants and additive solutions in those packs, devices such as our apheresis machines, all of these are therapeutic goods as well. Okay, sorry, just trying to go to the next. So where are GMP principles documented? Just trying to get that as a deep, so you can see it properly, sorry. Okay, where are GMP principles documented? These are our codes of good manufacturing practice, and that's where you'll find all the principles. Now, codes of GMP for pharmaceuticals have been around for many years. So the question is, can they actually be applied to blood components and tissues? And the answer to that is actually no, very emphatically no. And the reason for that is because blood and tissues are biologicals, not pharmaceuticals or medicinals. Now, if you think about raw materials for medicines, it's easy for pharmaceutical manufacturers to actually buy chemicals in to a certain standard purity, and they can test it, and every batch of that particular chemical is the same purity. Our raw materials are our donors, and we can't standardize them. Their weight, their age, their gender, their health history, hemoglobin, blood pressure, etc., all vary between donors. So one batch is one donation. So in pharmaceuticals, you make a 10,000 pills, they're all one batch. For us, one batch is one donation. So the pharmaceutical GMP it's not suitable for us. So separate codes of GMP have had to be used for them or developed for the manufacture of blood and tissues. So now if we look a bit more closely at these codes of GMP for blood establishments, some of them have been developed internationally. For example, WHO, this one down here, PICS, which is this one here, the Pharmaceutical Inspection Convention, or some have been developed as country-specific, like the Australian Code of GMP. So WHO and PICS are used by lots of different countries. We here use the Australian Code. The most recent versions are 2011 for the WHO, 2021 for PICS, and 2013 for our standard. Now, before these, there were quite a lot of different versions, but GMP's become a lot more stable now as we've settled down. We've got good GMPs that work well with our processes at the moment. Okay, looks like, okay. So what is the scope of our GMP? Well, simply, GMP applies to the whole manufacturing chain. And by that, I'm talking about the entire manufacturing process from donor selection to component distribution. But I'm also referring to the support systems like donor selection criteria, management of critical materials and equipment, critical processes and critical control points, staff, documentation, storage, transport, and handling. So the question now is, if we think about it, does a blood service only need a code of GMP? Unfortunately not, because codes of GMP focus on principles, not specifics. And that's why they can be used, widely across a lot of different types of components. We need to select a blood standard for detailed specifications. And a good example is donor selection criteria. I'm looking at the Australian Code of GMP at the moment, and clause 804 says, donors should be selected according to documented procedures defining the selection criteria, infectious disease screening tests, and any other relevant tests. Full stop. That's all it says. Now, if you go to a blood standard, you have a blood standard, that is where you will find the fact that donors must be over the age of 18 and less than 65. They must be over 50 kilograms in weight. Their blood pressure must be this. Their health history must be that. So that's where the detailed specifications are actually put out. And it's the same for components. The GMP will just talk about components meeting specifications when you've made them. The blood standard will give you those detailed specifications. Now, these blood standards can also be developed locally or selected from international standards. And I've only given 2 examples here, AABB standards or the Council of Europe guidelines. And in fact, in Australia, we use the Council of Europe guidelines. So if you look at the contents of GMP, they are very similar. So if we look at the 3 that I put up as examples, you can see here that they've got a lot of commonality. So they cover the same topics. The words that I've highlighted in blue here are specifically technical requirements that are specific for blood and tissues. Whereas the ones in red, these are common. They are basically the quality management system requirements that are common to all quality management system standards. If you actually take ISO 9001 or ISO 15189 and you look at the contents, you will see that both of those documents will have things like training and people, premises and equipment, documentation, material, subcontracting, feedback from customers and complaints, QC, computers, etc. So that's a good thing about GMP. It has in it a large component of quality management system as well. So you don't need to also go looking at 9001 or some other quality management system to implement as well. CGMP covers it all. So if we look now just at the individual requirements, starting with quality management, and I'm really going to whip through the Australian requirements because they're the best set out and they're just the easiest for me to summarize. The others are a bit more complex. The section on quality management states that, there really needs to be a documented quality system to give your staff a quality policy and quality objectives. These should include QMS, this section also refers to a few quality management system requirements that aren't covered in other sections. For example, the fact that you should document, investigate, and approve formally any components that are actually deviations from your normal system. And the approval is given by the authorized quality representative. Now, an example here is if you are collecting platelets of a particular phenotype, should I say a particular white cell phenotype, and you are going to give them to a patient who is desperately ill and is really life or death that they get these platelets. If there's a problem in your processing or your donor had a very low level of platelets to start off with, and you end up with platelets that are actually below your minimum requirements, well, what are you going to do? Are you going to discard that platelet simply because it doesn't quite meet that, but it's got platelets in it? Or are you going to use it and collect more? It's a non-conforming component. It's a deviation. You would go ahead and use it. But that decision should be made based on medical need and authorized by your quality representative. Also in this section, it refers to the need for a measurement and monitoring system and a change control system. This provides framework for quality and ensures that all staff understand the same objectives. I'm sorry, I just made that ever so slightly smaller simply because I need to be able to see what's at the bottom of the screen. So I'm hoping you can all still see this okay. Now, if we take the one thing that it includes here that's not in the rest of the document, and that's change control, this is a key part of GMP. All changes to your processes and products should be controlled. This ensures smooth implementation of changes, and it means that you need to identify, as part of your change control, you need to identify and mitigate any change risks. You need to plan your change carefully and actually develop a change plan. You need to document and complete all the activities in that plan, who does what and when. And once you've conducted all of those activities and completed them, there needs to be a formal review and approval of change before implementation. One very important thing is that you need also to review the change. Once you've implemented that change, review it some months later. I've put X here because it depends very much on what you set. It could be 3 months after implementation. It could be 6 months after implementation. You may want to do it at 1, 2, or 3. All of that would be in your plan. But having a change control process reduces the risk of unexpected adverse impacts to quality or safety caused by the change. It makes you think, is this change going to affect anything upstream or downstream in the processes? The other activity that was singled out in this first section is monitoring. Of course, monitoring is really important to monitor all your performance, both your quality system performance and all of your manufacturing processes. Your systems provide data and information to help you improve. And some of the systems that you need to put in place are the internal audit program. That's extremely important. The corrective and preventive action, where you are recording any non-conforming product or processes, which you may need to quarantine, you may even need to recall. That needs to be part of your CAPA. You are recording incidents, adverse events, and you are actually investigating all of them to find the root cause and then introducing corrective and preventive actions. There needs to be regular management and product review. Now, management review is common to all quality management systems, where you have a management review meeting and you look at all of your performance indicators, all of your audit results, your outstanding CAPAs, you look at supplier problems, you look at all of those, you look at your quality control results, and of course, you really make sure it's all working. So you're looking at the effectiveness of your processing, but also your quality management system. These days, GMPs also require a product review, where you are reviewing specifically the products you are producing. So you're looking at in detail at defects that are being reported, reports that have come in from hospitals. You know, you're really focusing on that. The two of these can be done as a single meeting if you're prepared to make it quite a long meeting, because it has to be a fairly thorough review. Or you can separate it. Management can look at the quality system and staffing issues, etc. Product review can look only at the products. And when it needs to be done regularly, you set the time frame, whether it's every 6 months or 12 monthly. The codes only say at least annually, so at least once a year. The important thing is, I would always recommend to any organization who's putting GMP in for the first place, start doing your review every 3 months, then go out to 6 months, then to 12 months. Because in the beginning, you want to review how your implementation is going. And the last thing here is customer feedback. Very important to get customer feedback. And of course, this reduces risks of trends happening or any unexpected problems occurring that are not identified at an early stage. So if you're doing this review regularly and you're carrying out all this monitoring, you'll pick up those trends and those problems much earlier. Now, personnel and training. People play a critical role in risk management, obviously. You need to have enough staff, both for operational and GMP activities. So you therefore need to have, if you look at the opposite side here, management support to ensure that you get sufficient staff. The staff need to be suitably qualified, so you need to have a good recruitment process. Staff need to understand roles and responsibilities and have enough authority. So you need to have organizational charts and job descriptions. And of course, last but not least, by any manner, need to be competent for assigned tasks. Therefore, you need to have a very good training and competency assessment program in place for all staff. And that's not just initial training, it's ongoing and refresher training as well. These all reduce the risks of gaps and overlaps in staff responsibilities. They know clearly what is their responsibility and not someone else's. This reduces the risk of errors, inconsistency, etc. Now, I've been putting at the bottom of every requirement the risks that this particular requirement addresses, because I really want to drive home the fact that GMP is a risk management strategy. There are a couple of key positions for GMP. They do specify there needs to be a quality and a production nominee. And this is particularly important if you become formally regulated, because these are the people, the two people that will go on your manufacturing certificate or license, or, you know, that will liaise with your regulator. These must be separate positions, independent of each other. The production nominee has responsibility and authority for all the production activities and for maintaining GMP compliance through those production areas. Whereas the quality nominee, often called a quality manager, but more recently standards are calling this person a quality representative. Not so much a quality manager. It's up to you. But this person is somebody nominated to have the responsibility and authority for overseeing and approving or rejecting all quality related processes and products, and approving any use of non-conforming products. So having these two positions and being separate and independent reduces risks of inconsistent decisions or bias. You don't want the production nominee to be responsible for approving non-conforming products because they have a conflict of interest. Premises are really important. Their design, construction, and use should be fit for purpose. And certainly the codes talk about certain areas needing to be separated. For example, collection, processing, and testing have all got to be separate to each other. The design and construction has to focus very much on protection of product, not just blood components, but materials, equipment, and confidentiality of your records. They need to try and ensure minimization of error by allowing good, safe workflows. A good workflow is invaluable in reducing staff errors. It should allow efficient cleaning and maintenance to prevent contamination, and should also have things like good security, emergency power, and environmental control, dedicated waste areas. And again, this reduces the risks of errors, harm to staff and donors, and contaminated or compromised products. Now, mobiles. This is something that causes more problem than, you know, almost anything else in GMP, because the aim is to try and be able to use the same processes, materials, and equipment as you use at the main blood center. And we all know that that often just cannot happen. What you need to try and ensure that the size and construction of any sites that you actually set up mobiles in, like a hall or a gymnasium or some big office complex somewhere, should be able to allow an acceptable, safe manufacturing practice, and should be able to protect products and materials. So you should be able to arrange things to make sure donors don't go walking through equipment and through materials, etc. They should also be inspected and formally approved as suitable before the first session is held. In other words, they need to be qualified. This is often a stumbling block, and that is why more increasingly blood services are actually starting to use bleed on board buses like this one, which this design works really well in Indonesia. But making sure you're running a safe mobile reduces risks again of errors, harm to staff and donors, and contamination or compromised products. Critical equipment, and I'm talking about equipment that can affect quality and safety of either products, staff, donors, patients, not things like the refrigerator you have in your staff lunchroom where they keep their food. They should be correctly installed, in other words, qualified and validated on receipt. So they must be checked for good performance. So you're proving that they work before use. And they should be monitored once in use by running controls, quality control, intermittently, checks, EQUAS panels, etc. So you're confirming that they're performing well while in use. And of course, you need to look after your equipment by cleaning, maintaining, calibrating, servicing regular, etc. So putting this in place reduces the risks of equipment failure and errors, and ensures that you're going to have reliable, consistent outcomes. Now, documentation is the foundation of any quality management system, no matter what industry you're working in. It's critical because it describes management's commitments in policies, sets out instructions for activities in SOPs and work instructions. These are used for training staff properly and effectively, and also includes forms that either collect information, but also includes labels. And I've put that in there because your donation barcode labels are critical labels and need to be controlled as good documentation. And the labels that you use to show that components have been released are also equally critical. Documents must be well written and controlled, in other words, up to date and issued to correct work area with out-of-date copies removed. This process here, of course, is called document control. So documentation is really worth getting right. It reduces risks of staff not knowing what to do or following outdated procedures. Now, the other side of the coin, you've got your SOPs that we had before. Once a form is filled out, it becomes a record. So you have a form which you fill out, becomes a record. These are critical because they give us evidence of actions and evidence that we've achieved a level of quality. They also give us traceability. Who did what, when, how, what was the result, etc. And traceability is extremely important. We must make sure that we handle them correctly. So we need to fill them out properly. No empty spaces. We need to make changes correctly. No using whiteout or Tipex or overwriting. And we need to store them under secure conditions for whatever length of time is required. GMP doesn't state a length of time. Some blood standards, I think, may, but generally it's up to you to decide on the length of time. If your regulator doesn't tell you how long, then you should follow hospital practice and keep them for as long as hospitals keep their records. Here in Australia, we have to keep our records for 21 years. So, you know, there you go. And we also need to make sure that when we have reached the end of our retention period, we destroy them confidentially. This reduces the risk of not having traceability for things like recalls or not having evidence of quality levels, and also maintains confidentiality. I haven't included that in there. Control of material is very similar to equipment. Critical material, in other words, things that can affect quality and safety of products, staff, donors, patients, they should be qualified and validated before use. Ideally, you want to really try them out before you agree to purchase or go into a contract with a new supplier. When they arrive, they need to be inspected and checked on receipt by your stores, and then again immediately before use. And this is called, excuse me, incoming inspection. Then they need to be verified before use if they are new deliveries, new lot numbers. And this is particularly important for testing reagents, because you want to make sure your test kits have not been compromised during delivery or between different lot numbers. So what you're doing here again, you're proving before you use, and you're confirming while in use, or verifying you could use as well. Handling and storage is really important as required by manufacturer. No use of expired materials if you can possibly help it. If you have to use any expired materials because you don't have access to any replacement, then you have to validate their use. You have to validate their performance again. And once in use, you monitor again through controls, QC checks, and reporting of any defects. And as with equipment, reduces the risk of failures and ensures reliable, consistent outcomes. Subcontracting. Now, we didn't actually, at one stage we used to subcontract out our not sterility testing, our bacterial contamination testing on components. But we then introduced our own testing, so we don't do it anymore. But if you do need to subcontract out any key activity in your process, you need to make sure that the subcontractor is evaluated properly initially. You may even want to go and do an audit on them. You need to regularly review their performance. Again, prove before use, confirm while in use. If they are not in a GMP area or they don't understand GMP, you need to provide some training. You may need to. And if they come in and work on site, you should supervise them. Key responsibilities should be set out in a formal contract, and the subcontractor should then not further subcontract out any activities without approval. So this reduces risks of them failing to comply with your quality management system and meet appropriate levels of quality and safety. I'm sorry, I know we're starting to run a little bit over time. I'll try and hurry up. I've only got a few more slides. Complaints and recalls complaints and adverse events, I beg your pardon, should be documented and investigated. Corrective actions should be taken where indicated, but remember, you need to find the root cause before you implement your corrective action. You may find that recall of blood components is required. If it is, this should be able to be carried out urgently and at any time, in other words, after hours and over weekends, according to a documented recall procedure. This is where your traceability and knowing who's done what, where, when, why, and where that component has gone, where the ones are that are still in the building are. You know, you may have issued the platelets, but you may still have red cells and plasma within the building. Really important that you have good traceability. This also means that when you are dealing with an adverse event, the first thing you should always ask when there's a problem, are components involved? Do I need to put them on hold? Do I need to recall any? So always ask that question first. Any reasons for recall must be thoroughly investigated and corrected, and decision-making for the fate of recall components, whether they're to be discarded or after investigation, they may be released again. That all lies with the quality representative. And of course, good documentation. This prompt action reduces risks of non-conforming components harming patient safety. Now, I'm sorry, this should have been in drop down, but I'm going to work through. Collection, processing, and testing are all together in one section of our GMP. Processors should identify critical points that can affect quality and safety and put controls in place at those points. And they're called critical control points, or CCPs. Now, all I did here was to draft out a quick flow showing registration, selection, collection, component processing, and then you have your 3 components max. There may have value-adding steps carried out on them, like irradiation, leukodepletion, or cryo, or pooling, and then the components are released. Whereas after the donation, screening is carried out for these, generally these 4. Occasionally HTLV1 will be in there as well, depending on what country you're in. These are mandatory tests, and they can be either serology with or without NAT. What we have here in this dotted box is that from this point to this point, there's handling, storage, and transport involved to some degree or another. And so that is a really important overlaying process. And by doing a quality risk assessment of all these critical points from here to here, will give you your critical control points and your controls. So GMP will certainly guide you on some of them. Your blood standard will give you others, but it's still worth your while to do them. To do a risk assessment of all of your processes. Now, just looking at some examples of critical control points, we have here the activities. We have donor registration, selection, collection, and donor screening. The risk, perhaps a wrong donor is registered, perhaps incorrect hemoglobin and blood pressures carried out, perhaps risk factors in their health history are not identified, donation or collection, venopancreasite contaminated, labels and paperwork mixed up, blood pack surfaces contaminated, for donor screening, reagent or equipment failure or mix-up of samples. What the control and checks you would put in place here: ask the donor to give you their name, date of birth, etc. You'd want regular calibration and controls of any equipment and reagents in your donor selection area, up-to-date donor selection criteria, staff training. Venipuncture site contaminated, you need validated standard disinfection process, separate work surfaces for each bed, regular disinfection of all of those surfaces, control time frame for the time it takes to collect and for your handling, and donor screening, validation of reagents, in-run controls, equipment servicing and calibration. So you can see that these are the controls and checks you'd need to put in place. Just looking at the last three, the biggest risk in processing is that you end up with components that do not meet specification. You'd have your validated processes, calibrated serviced equipment, controlled timeframes for handling, QC programs, for handling, storage and transport, temperatures fluctuating madly, testing of storage of testing and untested components together, contamination of packed surfaces, wrong component released. And you would see that your controls and checks here: validated transport, servicing your fridges and freezers, clear segregation of tested and untested, disinfection of work surfaces, computer control of release, controlled status labels, one component release at a time. In a nutshell, a summary: all critical processes should be standard and validated, including test methodologies. All equipment and materials should be validated and used as per manufacturer's instructions. This is proving before use. Performance of all critical processes, methods, equipment and materials should be monitored regularly. You're confirming while in use. All staff should be trained and competent in those procedures. So this is reducing this, continuing to reduce risk of errors, contamination, production of non-conforming materials. I just want to mention in particular release, because components can only be released if donor meets all selection criteria, including the health assessment, if their blood groups are confirmed, and if they're non-reactive for TTIs. Their collection and processing timeframes and the environment in which they were processed is acceptable. Now, these are very difficult to do if you're trying to check all of these manually. Very easy to make mistakes. So an electronic or computer-driven release is the most reliable method with the least possibility of errors in those. Prevention of release before all criteria met should include physical quarantine, kept physically separated. Then after release, not only are the components clearly identified as being different from those that are still to be released, and you do that by either putting them in a separate storage area or controlling the use of release labels. This reduces the risk of releasing any unsuitable, untested, or infectious components. 2 more slides to go. Quality control. Quality of components should be assessed at regular intervals. But your sampling and testing program for your QC program should be representative for all component types, all manufacturing sites, all manufacturing methods, different equipment and types of materials, modes of transport. So this is really important to remember. So if you've got 2 different types of apheresis machine, you should be controlling both of them. If you're using 2 types of blood packs or 2 brands of blood packs, you should be controlling both of them. And the selected blood standard should set out the specifications for you. Your results are compared to those specifications, and ideally any failed components should actually be discarded. This is sometimes hard for blood services to do, to actually put to one side the components that they've sampled and then send them out. Sometimes the components are destructively sampled, so you're opening the pack and you have to discard them anyway. Sometimes you can take from a length of tubing. This reduces risks of your failures in your whole production process not being detected in a timely manner and release of out-of-spec components. And second last slide, computerized steps in manufacturing should meet the same quality system requirements as the equivalent manual steps. So this is important here. If you're putting in place a computer release step for release of components, then it should follow the same quality system requirements, checks and balances as if you were doing it manually. Systems should be validated and regularly monitored. You should implement change control if you update or change the software. Must be regularly backed up and secure from unauthorized access. Don't forget also to have recovery backup procedures that you may need if your system goes down. And for heaven's sake, check them regularly. Have a dummy run every so often, because if you don't, and one day your system crashes and you suddenly have to go and find all your SOPs and try and find out who's trained to do these, it's a big problem. Believe me, I know it happened to us. And any manual entry of critical data must be verified. This reduces any risk of loss of critical data and or loss of electronic process control and the need to resort to manual method. Finally, in summary, GMP principles are crucial in reducing risks by focusing on prevention of contamination, disease transmission, other adverse events, ensuring reliability of staff, processes, materials, and equipment by training, qualification, and validation, monitoring the performance of staff, processes, materials, and equipment, minimizing errors by using good SOPs, good workflows, and good training programs, appropriate facilities, design and construction, cleaning, hygiene and waste, etc., and good documentation and records, particularly traceability. And final point, Code of GMP should be implemented in conjunction with an appropriate blood standard. And so that's the end of that. I do apologize very much for going rather quickly towards the end there, and I apologize for going a little bit over time. Wasn't helped by a slightly late start, but I'm not sure if we have time for any questions now, but I'm happy to take any emailed questions if push comes to shove.
Thank you, Ms. Vee, for this informational and comprehensive talk. As Ms. Vee already said, we don't have any more time for questions. In case you have any questions, please let us know through email and we will get them answered from Ms. Vee. To close the session down, I would request Dr. Navjyoti Chaudhary, President, Asian Association of Transfusion Medicine, to please say a few words as closing comments.
Thank you, Dr. Aikas. Am I audible?
Yes, sir.
Thank you. Thanks to Dr. Armstrong, and we are all colleagues, and her contribution to the quality is known for years. And thank you, Dr. Armstrong, for giving your consent as well as joining this meeting. And I will not prolong this meeting, and we have learned a lot during this your presentation. And I'm sure it is the way to go. I will take your guidance in future.
Dr. Chaudhary, your voice is breaking up. I believe Dr. Chaudhary is traveling. He's not able to, maybe he's in a patchy network area. Anyways, with thanks to Ms. Vee, we hereby bring this webinar to an end. Thank you so much for to all the participants for participating. Thank you, Ms. Vee, for sharing your time with us. Thank you
very much for inviting me. Thank you very much for your kind attention, everyone. And please, any questions, if you send them all through AATM, they can be forwarded on to me. Happy to help at any time. Thank you and good night to you all.
Thank you so much.